Hello, and a very good morning. I am Dr. Ignacio Smith Montaño Callejas. Following the program, I am going to present the evaluation of the heart in the first trimester. The roadmap is the justification, advantages, limitations, technique, results, national and international experience, diagnosis, heart diseases in the first trimester, indications for echocardiography in the first trimester, and the conclusions. Between 8 and 9 weeks of pregnancy, the fetal heart already has its complete morphology, so most heart defects are already present. Using fetal echocardiography, it can be detected via the transabdominal and transvaginal approaches. Color Doppler is a very important fundamental tool for evaluating the fetal heart in the first trimester. A trained sonographer will be able to perform a complete cardiac exam 92% of the time. What is the rationale for early fetal echocardiography? The anatomical lesion is already determined during the very first weeks of pregnancy, which means that the heart malformation is already present by about the first 8 or 9 weeks of pregnancy. There are 3 main advantages. It reassures parents. It will ease the anxiety of couples who have a history of congenital heart disease. That is, those parents who don't want to wait for the conventional second trimester ultrasound. The second advantage is that the first trimester ultrasound is increasingly morphological and can diagnose major heart defects. And the third advantage is the possibility of an earlier termination of the pregnancy, especially in cases of severe congenital heart disease that are associated with extracardiac abnormalities and or lethal chromosomal abnormalities. As early as 1987, Gregory Devore published his first diagnosis of congenital heart disease in the first trimester. It was a heterotaxy syndrome that had a large VSD along with hypoplasia of the pulmonary artery. Also in our setting, Dr. Fernando Viñal and his group have published on echocardiography in the first trimester using the stick volume. There are different groups that have published when they use the 4-chamber view and the outflow tracts of the right ventricle and left ventricle. In first trimester echocardiography, it has a sensitivity of 50%. Also, Yagel, using 4-chamber, outflow tract, right ventricle, left ventricle views, evaluating the pulmonary artery to the aorta, has a sensitivity of 64% in the first trimester and increases to 85% in the second trimester. This group uses the 4-chamber view, the right and left ventricular outflow tract, the inflow tracts, the right and left ventricles, color Doppler, the evaluation of the AV valves, the diameters of the AV valves, and the diameters of the great vessels. Its sensitivity at 12 to 14 weeks is 84%, and it increases to 92% in the second trimester. There are several groups with extensive experience in evaluating the heart in the first trimester, and they have published numerous studies. The technique must be performed using both the transabdominal approach and the transvaginal approach. You have to use grayscale, you have to use color Doppler, and you also have to use pulsed Doppler. A complete examination of 90% to 100% of the heart can be performed in the first trimester. The optimal acoustic window is typically between 13 and 14 weeks. Also, some international centers perform fetal echocardiography up to 16 weeks. The fundamental requirement is that it is an exam that requires quite a bit of time and a lot of experience. The professional performing the echocardiography in the first trimester must have a great deal of experience, be trained in prenatal diagnosis, and be experienced in the second trimester in order to move down to the first trimester. The technique is very similar to the second trimester ultrasound, except that it is more difficult because the fetus has smaller structures and the fetus moves around quite a bit inside the uterus. And it is the same technique of the 5 views proposed by Yagel, cytosolitus, 4 chambers, 5 chambers, 3 vessels, and 3 vessels, and trachea, and it is important and fundamental. Color Doppler will be mandatory in the first trimester ultrasound. We're going to start with the 4-chamber view. Here we can see the structures, identifying the crux of the heart, the atrioventricular valves, and the heart axis to the left between 45 and approximately 20 degrees. We are going to apply color Doppler to see the filling of the chambers and the direction of flow. We are going to interrogate the tricuspid valve, meeting all the conditions at 0 angle, perpendicular to the tricuspid valve. You have to place the box between the ventricles and the atrium, and it is considered tricuspid regurgitation when it is greater than 60 centimeters per second. Remember that the great arteries at this age do not exceed a velocity of 50 cm per second. We see the 4-chamber view, 5-chamber view, 3-vessel view interrogation of the tricuspid valve. We evaluate the aortic arch, the ductal arch. We evaluate the ductus venosus with a triphasic waveform, the 4-chamber view, apical 3-vessel view, trachea. And here, 4 chambers, 5 chambers, antegrade flow at the level of the ventricular cavities. And you can see the outflow of the aorta with antegrade flow. In grayscale, we see the 4-chamber view. We're going to look at the cross of the heart. Aortic outflow in grayscale. Once again, the same thing, antegrade flow at the level of the atrioventricular valves. We can clearly see the outflow of the aorta and the 3-vessel view. On color Doppler, there is antegrade flow, and you can see the V there. Here we see the 3-vessel view. The trachea from left to right, the ductal arch, the aortic arch, the vena cava, and the trachea. Ductal arch, like a golf club, with antegrade flow with an anterior back, aortic arch with its supra-aortic branches, antegrade flow in the aortic arch. 4-chamber view, there is antegrade flow at the level of the atrioventricular valves. Here you can see the left ventricle outflow to the aorta, and it crosses at 90 degrees with the pulmonary artery. The 3-vessel trachea view can also be seen, again showing antegrade flow in both atrioventricular valves. Here we see the aortic arch with its supra-aortic branches with anterograde flow. Here we see the ductal arch and part of the aortic arch, the ductal arch without supra-aortic trunks, and part of the aortic arch. So color Doppler is going to be fundamental for seeing the filling of the chambers, the patency of the atrioventricular valves, and the direction of the flows. Here we can see a 90-degree crossing where we see the pulmonary artery in front and the aorta behind. 90-degree crossing. Again, from left to right, we see the ductal arch, the aortic arch, the vena cava, and the trachea. Antegrade flow in both has to be the same color. The crossing of the great arteries, pulmonary artery anterior, aorta posterior. The aorta that exits the left ventricle and goes toward the right shoulder and makes the crossing. The 3VT, the aortic arch, a cane-shaped configuration with antegrade flow and a straight ductal arch are seen. The technique, we're going to see it in full, the abdominal situs. We're going to look at the 4-chamber view, the cardiac crux. We apply color Doppler. We see anterograde flow across the AV valves. The cardiac crux appears intact, and the septum primum is visible. Here we can see that the fetus changed presentation. Here we are assessing the tricuspid valve. There is no tricuspid regurgitation. It looks normal. Now we're going to try to look again. 4 chambers. We apply color Doppler, antegrade flow in both. The outflow tract of the pulmonary artery and the aorta can be seen. You can see the 3 vessels there. Once again, we're going to look for a slightly better window in order to evaluate the outflow tracts more clearly. We have already seen that the 4-chamber view is normal. The fetus is in an ideal position. We evaluate the 3 vessels, and there you can clearly see the 3-vessel view. The trachea, pulmonary artery, aorta, vena cava, and the trachea. 3-vessel trachea view, there is antegrade flow. We have first evaluated the 4-chamber view. Now we move on to the 3-vessel trachea view, and the 3-vessel trachea view is clearly seen. So there we are evaluating the outflow of the aorta from the left ventricle. There is antegrade flow on color Doppler. The aorta emerges from the left ventricle and goes toward the right shoulder. It is going to cross with the pulmonary artery. The pulmonary artery arises anteriorly from the right ventricle. There we see the 3 vessels. There is flow in the ventricular cavities, and it can be clearly seen that there is flow in the ventricular cavities. We're once again evaluating the 3-vessel and trachea view. We're going to evaluate the arches. Here we are evaluating the aortic arch. There is anterograde flow shown in blue because it goes from anterior to posterior, giving rise to its supra-aortic trunks. Here you can clearly see the ductal arch with the inferior vena cava draining into the right atrium. We also applied Power Doppler. The direction of the flows is well defined and there is antegrade flow. Here again, evaluating systemic venous drainage. The inferior vena cava can be seen entering the right atrium. Antegrade flow in both the aortic arch and the ductal arch. So, we have practically completed the exam of the cardiac screening in the first trimester. Here we are seeing the outflow of the aorta from the left ventricle. There you can see the aorta emerging from the left ventricle. We apply color Doppler and can identify the ascending aorta with its antegrade flow. It can be evaluated there, so we finished the exam. We can say that it's a normal heart. We have made the Yagel's 5 views, and we have applied color Doppler throughout the entire examination of this pregnancy, which is 13 plus 5 weeks. Here we can see the 4-chamber view in grayscale, which looks normal. The cardiac crux, patency of the atrioventricular valves, there is no ventricular septal defect, and there is no effusion. The outflow tracts and the 3-vessel trachea view are seen. We evaluated the aortic arch, and we evaluated the aortic arch in the 3-vessel trachea view, and we evaluated the aortic arch and the ductal arch in the sagittal view, both with their antegrade flows on color Doppler. The results for diagnosing severe congenital heart diseases show an 80% detection rate of cases of complex congenital heart disease in the high-risk population when performed by an expert physician between 13 and 14 weeks. There has to be a pairing of the expert physician and the high-risk population. Here, for example, this group performs echocardiography in the first trimester and has a diagnostic sensitivity of 92%, and in the second trimester it increases to 94%. Dr. Carvalho has a diagnostic sensitivity of 81% in the first trimester, and it increases to 100%. And this group has a diagnostic sensitivity of 78% in the first trimester and has a diagnostic sensitivity of 100% in the second trimester. What are the disadvantages of first trimester echocardiography? First, the heart is very small in size, and therefore the image resolution is relatively lower. Let's remember that the heart between 11 and 12 weeks measures 7 to 8 millimeters. It's like a grain of rice. At 13 weeks, the heart measures 10 millimeters. Therefore, the exam is more difficult, the image resolution is lower, and it may be that the heart disease is already present and is difficult to recognize due to the small size of the structures. The examination takes longer because it is a difficult exam, the fetus moves, and in addition, it must be complemented with the transvaginal approach. It depends more on the sonographer performing the exam. It has to be an operator, a professional with a great deal of experience in diagnosing heart disease in the second trimester. There is a finding of uncertain significance, some tricuspid valve insufficiencies, and asymmetry of the cardiac chambers. And lastly, the natural history of heart diseases. That is, some heart diseases, as we already know, are progressive and will appear in the second trimester or in the third trimester, and therefore we cannot diagnose them in the first trimester. Thus, Dr. Simcha Yagel in 1997 published a paper in which he performed fetal echocardiography in the first trimester, in the second trimester, in the third trimester, and postnatal echocardiography follow-up, and it was found that there were certain congenital heart diseases affecting the chambers that were diagnosed in the first trimester, such as hypoplasia of the right or left chambers and some conotruncal heart diseases. And yet, some heart conditions were diagnosed only in the second trimester, others in the third, such as cardiac tumors, stenosis of the semilunar valves, and others were even diagnosed postnatally. Recently, in the year 2020, Dr. Kypros Nikolaidis' group published a study on diagnosing major heart defects through routine ultrasound in the first trimester. When there is an association with increased nuchal translucency, tricuspid regurgitation, and abnormal flow in the ductus venosus. There are approximately 93,209 pregnant women with no apparent chromosomal abnormalities. 200 were included, that is, 200 major congenital heart diseases were diagnosed. And it was assessed that some heart diseases were diagnosed in the first trimester in 100%, such as pulmonary atresia with an intact septum in 100%, and left ventricular hypoplasia with the AV canal in 92%, tricuspid valve abnormalities in 25%, and transposition of the great arteries in 13%. No abnormalities of the semilunar valves or the arterial trunk were diagnosed in the first trimester. In contrast, in the second trimester, 72% of pulmonary valve stenosis cases, 80% of transposition of the great arteries cases, and 39% of complex heart diseases, such as left isomerism, had already been diagnosed. In the third trimester, various other heart defects could additionally be diagnosed. And postnatally, some heart conditions could be diagnosed that were not diagnosed in the first, nor in the second, nor in the third trimester. The cumulative detection rate was that in the first trimester, more than 50% of major congenital heart defects were diagnosed. In the second quarter, 92%, and in the third quarter, 97%. Let's look at examples. Here we can see a hydropic fetus where we are now going to look at the heart in the apical four-chamber view, which is going to be abnormal, where a defect of the cardiac crux can be seen. Therefore, we are going to immediately suspect that we are dealing with a complete AV canal. With color Doppler, it can be better assessed that there is flow through the single AV valve. And here there is absence of the septum primum, a large VSD, posterior inlet, and a single atrioventricular valve. We are looking at a complete AV canal. Another case. From a patient who had a nuchal translucency at the 95th percentile, whose cardiac screening at 11-14 weeks was apparently normal, and this patient returned to have an evaluation at 15 weeks. We evaluated a normal four-chamber view, here a three-vessel view that appears normal, which we interpreted as normal, and here assessing the great arteries, which had a flow of less than 30 centimeters per second, and we interpreted it as if there were a normal outflow tract. Here we see the arches with anterograde flow, the aortic arch, the ductal arch. And here, when this patient came in during the second trimester, she had a transposition of the great arteries. It was a false negative at 12 to 14 weeks, and we picked it up at 21 to 24 weeks. In addition, he also had a perimembranous VSD. It was a transposition of the great arteries. Here is a patient at high risk of aneuploidy because she had a positive tricuspid regurgitation. She had a ductus venosus with a reversed wave, and that put her at high risk of aneuploidy. She had a risk for trisomy 21 and trisomy 18. At 16 weeks, there was a view here, a four-chamber view in which two echogenic foci can be seen in the left ventricle and inlet VSD. We were also suspecting a probable AV canal. You can see that there is an absence of the septum primum. Here she was 16 weeks. When she came in at 21-24 weeks, this patient had a tetralogy of Fallot complex, where you can see aortic override here. And in the three-vessel trachea view, there is reversed flow in the arch, in the ductal arch. We are facing a complex Fallot type, pulmonary atresia. More examples. Another patient who was referred because there was a suspected heart condition, so we evaluated her, and also a diaphragmatic hernia, because there was the presence of an anechoic image in the chest, stomach. You can see the heart, which is in marked dextro position, an altered four-chamber view. Practically, you can see a single valve. A single ventricular cavity, the left-sided chambers are completely hypoplastic and practically do not exist. In the three-vessel trachea view and the sagittal view, there is reverse flow in the aortic arch, there is antegrade flow in the ductal arch, and reverse flow in the aortic arch. So we are facing a duct-dependent congenital heart disease, which is a hypoplastic left ventricle syndrome. Here you can clearly see that there is reverse flow in the aortic arch. We carried out our experience from 2013 to 2015 in the 11 to 14 week screening exam, and we took 30 minutes as recommended for the exam. The data are recorded and documented in the software of the Fetal Medicine Foundation, the Astraea program. The examination is performed via the abdominal approach and via the transvaginal approach. We presented this work at the 2015 World Congress of Perinatology, and for the technique, we used the 5 Yagel views: 4-chamber, 5-chamber, 3-vessel trachea, evaluation of the AV valve, and the arches, both in the 3-vessel trachea view and in the sagittal view. We also evaluate the ductus venosus. We obtained visualization of the heart in 85% between 12 and 14 weeks. Color Doppler made it possible to identify the structures, the filling of the chambers, the direction of flow in the great arteries, and also to evaluate the arches in the sagittal view and the 3-vessel trachea view. We had 9 patients with nuchal translucency greater than the 95th percentile, and 6 patients at high risk for chromosomal abnormalities, 3 false negatives. Transposition of the great arteries was detected at 22 weeks, an arterial trunk and left ventricular hypoplasia with a restrictive foramen oval, which were detected at 21 and 26 weeks, respectively. Here we have the patient with hypoplastic left ventricle syndrome with a restrictive foramen ovale who was successfully treated at 24 weeks. And it is important that in order to perform the first trimester ultrasound, we have to be trained, we have to be certified, and we have to have quality control. And it is advisable to undergo auditing through the Fetal Medicine Foundation and to meet all the conditions for each marker, such as, for example, here, when evaluating the tricuspid valve, we need an apical 4-chamber view, magnify the image, the sample size has to be 3 to 4 millimeters, the insonation angle has to be practically 0, perpendicular to the tricuspid valve, the wave speed 4 to 6 waves. So we have to meet all the conditions in order to perform a good exam. Also, we want to tell you that our experience has grown, and we have now been doing this for 8 years. We have more than 2,500 patients for whom we have performed a first trimester heart evaluation during the 11 to 14-week ultrasound. We can also say that in Chile, there are 21 professionals who have submitted their images and have been audited through the Fetal Medicine Foundation. And as we already know, we have to renew our license in 11 to 14 every year in order to maintain ongoing quality control. In Bolivia, we have only 4 professionals, and we hope that next year this will increase. Here we have another case of diagnosing heart disease in the first trimester. A 25-year-old patient, gravida 2-1, with no prior medical history, who comes in, and you can see a dominance of the right-sided chambers. There are some small left-sided cavities, but they are not hypoplastic. There is antegrade flow, as you can see here. And it has mitral regurgitation. Here we can see small left-sided cavities that are not hypoplastic. So here you can see right dominance in both the basal and apical 4-chamber view. In the 3-vessel trachea view, there is retrograde flow in the aortic arch and a ductal arch that is wide like a cannon with anterograde flow. Here you can see it better. 3-vessel and trachea view, a wide ductal arch and reverse flow in the aortic arch. So we have predictive signs of hypoplastic left ventricle syndrome because there is reversed flow in the aortic arch, and we could be facing an aortic coarctation or critical aortic stenosis. Here you can see the 3-vessel view with reverse flow in the aortic arch, a sagittal view with reverse flow in the aortic arch. This patient progressed, and at 20 weeks it was a case of critical aortic stenosis. A globular left ventricle is seen with an echogenic wall, and the aortic valve is dysplastic with limited mobility, and in the 3-vessel view it is the same. We see reverse flow in the aortic arch. Here you can see that we were dealing with a ductus-dependent congenital heart disease that we suspected in the first trimester. This patient met the criteria for an intrauterine cardiac intervention, which was performed at 22 weeks by a multidisciplinary team, an intrauterine aortic valvuloplasty at 22 weeks, which was successful, but unfortunately progressed to a single ventricle heart. We continue with heart diseases with another example of heart disease in the first trimester. Here we see a fetus in an apical 4-chamber view, and you can clearly see that there is hypoplasia of the right-sided chambers. This is the left side, this is the right side, and here you can see a hypoplastic right ventricle and atresia of the tricuspid valve. When applying color Doppler, we see antegrade flow in the ascending aorta, and there is reverse flow in the ductal arch and in the pulmonary artery. Here in a left ventricular outflow tract view, you can see, here we see that the aorta emerges from the left ventricle, forms the aortic arch with anterograde flow, and here there is reverse flow in the ductal arch. And we can also clearly see a structure showing bidirectional flow that we suspected was a coronary fistula. So here we again see the four-chamber view with color Doppler. There is univentricular inflow into the left chambers, and there is no flow in the right chambers. Examining the left ventricular outflow tract view, we see that the aorta emerges from the left ventricle, goes toward the right shoulder, and forms the arch with antegrade flow. And here we see the structure with systolic and diastolic flow, which raises suspicion of a coronary fistula. So here again, we see antegrade flow in the aortic arch and reverse flow in the ductal arch. Here, this red color indicates reverse flow in the ductal arch. So we have univentricular inflow into the left-sided chambers, the ascending aorta with antegrade flow, and reverse flow in the ductal arch. This is pulmonary atresia with an intact septum with a coronary fistula. Here you can see reverse flow in the ductal arch and the coronary fistula. And here we see the high-speed bidirectional flow both in systole and in diastole, there in the coronary fistula. Here, when it progresses to 25 weeks, there is reversed flow in the pulmonary branches and also reversed flow in the ductal arch. And here, in the third trimester, the left chambers are normal with good left ventricular contraction, and the right chambers are hypoplastic. And here you can see the coronary fistula with bidirectional flow, systolic and diastolic. Coronary fistula, pulmonary atresia with an intact septum. Another example, a patient who had a pregnancy resulting from assisted reproduction who comes in for her 11-14 screening, and a ductus venosus with a reversed wave is detected. The right ventricular outflow tract is normal, but what was observed was that the left ventricle was hypoplastic. When we performed the sagittal view, it also showed reverse flow in the aortic arch. Here is the four-chamber view. There is univentricular inflow into the right-sided chambers. The left-sided chambers are extremely hypoplastic, with reverse flow in the aortic arch. This is also another case of hypoplastic left ventricle syndrome, a ductal arch wide like a cannon, and an aortic arch with reversed flow. And here, in the three-vessel trachea view, we see reverse flow in the aortic arch. We also see that the pulmonary veins already had an altered morphology. The A wave was somewhat reversed, so this patient would probably progress to left ventricular hypoplasia syndrome with a restrictive foramen oval. Another case, a patient who comes in for her 11 to 14 week screening had a normal nuchal translucency, a normal tricuspid valve, and a ductus venosus with a present wave. And when evaluating the outflow tracts, it can be seen that there are two vessels in parallel side by side. And by applying the dual color, it is easier to distinguish that two vessels are parallel in the shotgun barrel. And in the three-vessel trachea view, we see two vessels here, so we suspect that we are dealing with a conotruncal heart defect. Here you can see the pulmonary artery with its branches, and here we can see this vessel that arises from here, overriding the interventricular septum, which would be the pulmonary artery, and this anterior vessel, which would be the aorta. So it would be a double outlet right ventricle, like transposition of the great arteries. And in the three-vessel trachea view, we're going to evaluate two vessels, the skateboard sign. This would be the transverse aortic arch. The pulmonary artery is not visible because it is posterior and inferior, because we are dealing with a double outlet right ventricle of the TGA type. It has a subpulmonary VSD, the aorta is anterior, and the pulmonary artery is posterior. Here, on Power Doppler, you can see the anterior aorta and the posterior pulmonary artery, and there you can see the VSD. And the pulmonary artery emerges from both, from the RV. That is, the pulmonary artery is overriding the pulmonary valve. It overrides the interventricular septum. Double outlet right ventricle, transposition of the great arteries type. Here you can see the same thing with Power Doppler, and here it is seen clearly. This would be the anterior aorta and the posterior pulmonary artery, and here you can see the subpulmonary VSD. 2 vessels in parallel, side by side, emerging from the right ventricle. 3 vessel trachea view, 2 vessel view, skateboard sign. In the stake volume, we see here 2 vessels emerging from the right ventricle. Another case, the patient who comes in for their 11 to 14-week screening with a history of methotrexate use up to 7 weeks. And we found a present positive tricuspid regurgitation, a venous duct with a normal waveform. And when we apply color Doppler to the heart exam, we see that there is a single ventricle flow and the left-sided chambers are completely hypoplastic, practically like a single ventricular cavity. Here, in the 3-vessel trachea view, we see reverse flow in the aortic arch and it is smaller in diameter, it is hypoplastic. So here we see, in the sagittal view, retrograde flow in the aortic arch and antegrade flow in the ductal arch. In the 3-vessel trachea view, antegrade flow in the ductal arch, retrograde flow in the aortic arch. We are again looking at another case of severe hypoplastic left ventricle syndrome. Here again we see the pulmonary artery with its branches. Here we see essentially what looks like a single ventricle, and there is also significant tricuspid valve regurgitation. Dilated right heart chambers with tricuspid valve regurgitation. There you can see tricuspid valve regurgitation, univentricular inflow, dilated right chambers, and the left chambers are hypoplastic. And when we scheduled this patient for reevaluation at 15 weeks, we saw the same thing. A wide ductal arch like a cannon and an aortic arch with reversed flow and a smaller diameter. Then we would be facing a left ventricular hypoplasia syndrome. Due to mitral aortic atresia. You can see it here. And lastly, we also have this patient who comes in for her 11-14 screening, and a ductus venosus with a reversed wave is found. And what stands out is 2 things, that the axis of the heart shows marked levocardia, and in addition, the outflow tracts were altered. We suspect a conotruncal heart defect. Here you can see the axis with marked levocardia and the outflow tracts altered. We were struck by the fact that we were only seeing a single grade vessel, and we suspected a truncus arteriosus, so we scheduled this patient for a fetal echocardiography, and she came in at 15 weeks, and you can see that it was a grade vessel emerging mostly from the right ventricle with a large VSD. This vessel is overriding the interventricular septum, and we couldn't see the pulmonary artery arising from the heart. In other words, we're facing a suspicion of a truncus arteriosus. And here we can see in the cross-section 3 vessels, the trachea and a large dilated vessel. So, in the 3-vessel trachea view, we also see 2 vessels, the transverse aortic arch and the vena cava. That is, it's a suspected conotruncal heart defect that would be an arterial trunk. We do not see the pulmonary artery, or it could also be another conotruncal heart defect, which would be pulmonary atresia with VSD. What are the indications for echocardiography when there is a history of congenital heart disease, which increases the risk of congenital heart disease by 2 to 3 times? Altered aneuploidy markers. When new-child translucency is increased above the 95th percentile, it is associated with 10% to 15% of severe congenital heart defects, with a 5% false positive rate. When we are going to use the 95th percentile, we have to perform 33 tests to diagnose a heart disease. And when we use the 99th percentile, we have to do 16 patients to diagnose a heart disease. Another indication would be when there is a ductus venosus with a reversed wave. It is associated at 20% with severe congenital heart diseases, as we have seen in the examples, with a 20% false positive rate, and it increases the risk test for congenital heart disease in euploid fetuses. Tricuspid regurgitation. When there is regurgitation of the tricuspid valve of more than 60 centimeters per second, it is referred to as tricuspid regurgitation. This is associated with 20-30% of severe congenital heart disease with a 10% false positive rate. Another indication is monochorionic diamniotic pregnancy, which increases the risk of congenital heart defects by 5 to 10 times. And pregnancy through assisted reproduction increases by almost twofold the risk of severe congenital heart disease. And lastly, pregestational diabetes, which is also an indication for early fetal echocardiography. In conclusion, we can say that early fetal echocardiography is indicated in the high-risk population and must always be performed by a physician who is an expert in the diagnosis of heart disease and prenatal diagnosis. The timing of the exam must be between 12 and 14 weeks. It can be extended up to 16 weeks, and the approach must always be transabdominal and supplemented with a transvaginal approach. High-resolution, top-of-the-line ultrasound machines should be used, and it should be kept in mind that the exam, the first trimester echocardiography, does not replace the second trimester echocardiography. That means that even when we evaluate a normal heart in the first trimester, we still have to perform the standard, conventional second trimester echocardiography. It will not replace it, rather it complements it. Thank you very much. If you have any questions, here is my email address for your reference. I am at your disposal for any questions or concerns you might have. Thank you very much for your kind attention.